All right, good afternoon, everyone.
Good, good afternoon.
Hi. All right, so today we have Mrs. Sharon Williams Brown. She is a senior counselor at the University Health Center, and she's going to be talking to you on the very, very important topic of dying, death, and bereavement. I thought she was coming in. So guys, remember to keep your mics muted unless you're actually going to speak, because sometimes the background noise feeds in and it's a little bit distracting. All right, so I'm going to turn you over to Mrs. Williams Brown now, and she'll take you through today.
Thank you very much, but let me ask one technical question before we start. The muted mics, how do I mute the mic?
So you are fine now.
If somebody's speaking and I want to mute my mic.
Oh, so Sebastian apparently has taken all our powers away.
Okay.
Hold on, let me see. Oh no, here we go. So if you just bring the mouse up to the top here,
okay,
then it will come down and you can just click mute over here. Yes.
All right, okay.
Yes.
It's set up differently than the one I used before. Yeah.
Yes.
All right, otherwise I'll hold up for Sebastian.
Right, and he's listening, so
Okay.
he will.
All right, so thank you very much, and good afternoon to everyone who is there. Right, I have one live person on site. It's Keon. Okay. Although it's a distance lecture, I'm hoping that we'll be able to share experiences as we go through. So I'm very open to questions and comments, not just stuck on the slides, which you will see as we go through. So let me just get a little bit about each person since I don't have a bio on you all. So I see George, I think. And just asking, what I'm really asking is for you to tell us a little bit, each of you, about what your experience has been in terms of dying, death, and bereavement. I also normally preface this lecture by saying that some of you in here may have recently experienced loss. And so it is quite possible that what we talk about will bring up personal issues. Hopefully it doesn't become overwhelming, but if it does, and you need to excuse yourself, that's perfectly understandable, but I hope you'll be able to stay with us. And so let me hear from, I'm gonna have to pick on people. George, since I got your name and see your face, what has your experience been like?
I'm a physician at a geriatric hospital here, and yes, I've had personal losses. It was very hard initially in the first few months, I would say. But for me, it was faith in God and hoping for a better future, I think, and getting, it was sort of a mixed feelings, but it was very hard initially. But I found, I can tell you that time is a big healer, and in my personal experience, what I have lost has come back to me in different ways. So I continue to praise God for what I have experienced, and that's what I can share. But the immediate time was very hard.
Okay, thank you, George. There is another gentleman on screen, it appears, whose name I don't have. Would you want to share a little bit with us, two of your experiences?
Okay. Good afternoon. My name is Dr. Govi. I'm working to the geriatric hospital in Nassau, Bahamas. Can you clarify this question? Like, you mean my experience with dying, death, and bereavement? That's the question?
That's the question. And it can be in your professional capacity or in your personal capacity, whichever way you want to speak from.
Okay. No, I could speak from my professional capacity. So I work in the geriatric hospital about 1.5 years. And I see sometimes, the elderly people they're frail. You know, like when sometimes we think that there are times, you know, like we think that, so this person, he will not make it. But I mean, amazingly, he will come out. I mean, with glory. And one fine day, so everything is fine, then he will. I mean, like we don't expect him go like that. So this happened in 2 days back. One of our patient, everything was fine. He eat and everything, drink and everything. He just passed away, just like that. And many of the time, that's the thing about the geriatric. Many of them, you may hear the DNA, their status and all that. Before coming to the geriatric hospital, I worked in the accident emergency about 16 years. So always we regularly briefing to the family, their loved ones passed away in an accident and a heart attack and like a gunshot and stab wounds and all that. So many times over many years, and I had that exposure of briefing to the family, grieved one.
Okay, thank you. I see we have some names without faces. I don't know if Beth Ann, Karine, or Risha want to say anything.
All right, so my name is Orisha Denbo Burke. I mean, I'm a medical doctor here, and I've seen a lot of people dying, even, you know, in my hands, under my care, especially at the hospital. A lot of renal patients that I've worked with in the dialysis units I would have to speak to their families after dying, and so on. So it has been a lot for me.
Okay, thank you, Orisha. Anyone else wanting to comment?
Okay, my name is Beth Ann Spencer. I'm presently a social worker. Personally, I've not really experienced any dying, death, or bereavement, luckily. But I do have a phobia for it, especially the process, serious phobia. Sometimes, especially when it comes to my family, especially my son, there are times when I actually just think about what may happen to him and how I would actually deal with it. And sometimes I just go in depression, just the thought of it. So I really do have some sort of fear for it. And I really don't know how I would handle it.
Okay, thanks for that, Beth Ann. I commented possibly before you joined that this could be a challenging class for some people, so it may be for you as well too. Because as you said, not having had the experience, but you're going to be hearing us talking about this, it can bring up some of those anxieties and fears. But also if it gets you thinking about it, you know, it's something to begin to process, as I think will become clear earlier, later on in the session. I now have 3 people here at Mona with me. They don't have mics at their table, but the question, because 2 just came in, was what has been your personal experience of dying, death, and bereavement with the elderly? So if anybody here wants to comment, I think you'll probably have to come up to the mic. Would you?
I have a big mouth.
Okay, are you hearing the person who said I have a big mouth?
We have to share.
You don't have to. This is not compulsory, but if you want to, then for the folks at Mona, if you're going to want to say something, just come up and use the mic that's on the table where I am, please. And just say your name and then tell us what your comment would be. Well, everybody knows your name except me.
I'm sorry for being late.
Okay.
They can hear me from right here?
I think so.
Hi, George. Hi, Govi. Hi, Beth Ann and Orisha. I'm Toshane Young. Nice to meet you.
Okay. Nice to meet you, Toshane.
I lost my grandfather probably a year and something now.
Mm-hmm.
He had Alzheimer's, so it's kind of a touchy topic because learning about stride and, you know, and when I was at the what we call it, the thing the other day across the road. Yes, it was just right in my face, and then I had no idea so many persons were affected by the same thing. And then when I saw people crying after losing relatives from years ago, it was very, yes, emotional. And I'm a cry person for a long time, so it was very, I had to muster a whole bunch of courage not to fall apart. And then every time I see other senior males, my heart goes up to them if they're in a certain condition, because sometimes you see them on the road and whatnot, and it makes me think. But then because we were close, I miss him so often, and because he was at home, we were all helping to take care of him. So I'm so raring to go with the whole comeback, if I should use that word, of Alzheimer's Jamaica. So but this subject though, because when I was at school before, we had this class called grief counseling, and I don't know if, and I guess it's something you don't get over, I don't know, because I feel I just got here, but then I'm feeling, I don't know if scared is the right word.
A little anxious, it sounds
yes,
like.
Of what the whole topic will be.
Okay.
But I'm glad to share, because some of the classes I am at a total loss. So I'm glad I find something I can jump right into. Yeah.
What's your professional background?
I'm a social worker.
Okay.
Yes,
okay.
With senior citizens in the parish.
All right. So the fact you're with the senior citizens means that sooner or later you're going to probably be having to deal with that with them or their families at some point. Okay. Thank you very much. Okay. So you might want to sit a little closer in case you need to jump up and come up here again. All right. Anybody else want to comment briefly?
Well, I suppose I've experienced death, dying, and bereavement from both the personal as well as professional standpoint. It might be easier to talk about the professional. So it was a bit of culture shock for me, because when I was a younger doctor, just coming out of medical school, I didn't expect it, because they train you, that you talk about it and you do it in class and so on. But when you're a student, you don't really feel the full effect of it, because you are not the main one carrying the news. Mm-hmm. But then when it fell in my lap for the very first time, it was very emotional for me, because I felt to cry too. Mm-hmm. And I am the one delivering the news and trying to compose myself, and the people are, I also felt after a while that it became, there was a bit of detachment that mm-hmm. was required in order for me to be able to deliver the bad news effectively, and mm-hmm. to be there as a support in some way for the family members of the persons who have passed away. And I found that for me has been the biggest adjustment between before I was a doctor and after, where that mental sort of adjustment that you have to make in your mind to be the bearer of bad news, and to be the deliverer, or to be the person to try and intervene and not be successful, and still have to go mm-hmm. and face the patient's relatives and so on. That whole interplay was difficult, and still is, even to today.
Okay, thank you for that. And it's certainly, I think for doctors is one of the challenges, because your training is save lives, and then here's a life you can't save. And how do you deal with that fact? As you said, you're dealing with a loss for yourself. This is a patient I lost, but then you're also trying to support the family in the loss of their family members. So yes, it is a complex situation. So if there are no other sharers right now, then we're going to move on to talk about the objectives of this session. Quite a few. So I will go through some things fairly rapidly, but if I'm going too quickly, if you want to make a comment, please stop me and I will comment. So at the end of the session, we hope you will be able to discuss the inevitability of mortality and how that is contextualized in the Caribbean, describe and define elements of the dying, death, and bereavement process, and some of you are more familiar with one than the other, discuss strategies for preparation for death and coping with death and bereavement, identify issues of spirituality and ritual that accompany the dying process within the Caribbean, and identify common legal and ethical issues related to the dying process among the elderly, and then end-of-life decision-making and resolution of family conflict. After I've read all of this, I go, you know, in actual fact, I just finished teaching a grief course in another thing, and that course took us 4 weeks going through half of what's on here. So you understand that this is going to be a hit and run type situation. We're simply raising ideas for you to be aware of and for you to, if you are interested in the area, do more research on. There is a reading list that has been sent, which I trust all of you got, and that's something, some articles, a couple of books, if you're interested in reading further in this area. So, wanted to start off with a context that those of you in medicine probably are well aware of, and that's that life expectancy at birth in the Latin American and Caribbean region rose from 52 in the early 1950s to 73 in the 2005 to 2010 period. Info a little dated, but I don't think there's been a huge shift since then. That is in contrast to the fact that life expectancy at birth in North America in 1900 was 48 years. So you can see we've come a long way. And the life expectancy in Latin America and the Caribbean in 1900 was actually 29 years. So, I mean, we have, you know, doubled and gone further than that over the century and more. But when you think about that, it was an extremely short life expectancy a little more than a century ago. So a lot of changes. Of course, the rise of antibiotics, vaccinations, just general healthcare improvement, that all of that has taken place. Of course, there's still a wide variation, the low of 61 in Haiti to 78 or more in Chile, Costa Rica, and Cuba. In Jamaica, since that's where I am, I got prejudiced and pulled that. I didn't know about the Bahamians, so I didn't pull you all. But the 2015 WHO data, male 73.9, female 78.6, the average therefore 76.2. So in 2010, a little bit lower. So again, we still keep seeing these marginal increases over the years. Of course, what strikes you there is true, I think, right across the world. Women outliving the men is something which is not unusual in other countries also. So, just a comment also. I'm going to read, just to go back a minute, to that whole matter of women outliving the men. This was a Jamaican article published in 2012 in the Gleaner, which talked about wives outliving husbands. And it said the national census finds more than 55,000 widows to just over 18,000 widowers. As a Jamaican women then were 3 times more likely to outlive their husbands. The sex differential for widowed persons was considerable, with the number of women in the state of widowhood more than tripling the number of men, read a section of the census report. And the Statistical Institute of Jamaica pointed out that widows accounted for a quarter or 25% of the 65 years and over age group, compared to a low percent for the 45 to 64 years group. So women are beginning in their 60s, mid-60s to lose their life partners at a far greater rate than the men are beginning to lose their life partners. So that gender differential is something that we need to, or sex differential is something that we need to be aware of as we're working with the elderly. You're likely to see a lot more women in the older age group than you are likely to see the men. So you're 85 and over, likely to be a lot more of the women than of the men. Top 10 causes of death in Jamaica. Again, I pulled our statistics here from WHO 2015, and you're probably familiar with this. So stroke and heart disease topping the list, followed by diabetes, prostate cancer, HIV, AIDS, hypertension, violence, breast cancer, kidney disease, influenza, and pneumonia. So people expect death as they age or get ill, but many are still not prepared for it, because in terms of public health, we're all aware of this. The messages are out there on the TV, radio. We know that these things happen, but the issue of will it happen to me tends to be what the message people don't actually take home from what they're seeing. But as we get older, they say only two things are certain: death and taxes. That's a debatable statement, but you know, if you live long enough, you are more likely than not going to at some point be dealing with the issue of your impending death. However, the elderly deal with many deaths. So there's a prospect of their own death. There's the death of a partner, very likely. Death of friends. So you're looking at your 80-year-olds and their best friend died 2 years ago, and this other friend. I'm actually getting into the age group, although I'm certainly nowhere near 80, where I said to somebody the other day, the social event for my age group is going to funerals. When I was younger, the social event was going to weddings. But having passed a certain age, you are attending a lot more funerals than you're going to any other social event, it would appear. So it's death of friends. Some people face the real difficulty of death of a child. And of course, when violence and car accidents are a big part of our statistics, that is not just confined to the elderly. But again, as you get older, it is more likely, especially for those who had a large number of children, that one of the children could pass before you do. And then there's also the issue of what we call secondary losses. So there we're pointing out the inevitability of not just death, but loss of health comes to most people as they age, loss of mobility, loss of independence, loss of home and community, because they may be moved. I saw this with my father, very embedded in his community. But because of his health issue, having to move to live in Kingston, a place he abhorred all his life, but has had to be living here because of quality of medical care that's needed here versus in a rural area. So the secondary losses accumulate over time, and this can be very stressful for the elderly. And these can actually make some people long for death. So we're going to go on to talk. Any quick comments on anything said so far? All right, then we're going to talk about possible reactions to anticipated death. So death may be expected or unexpected with older adults. And when it's expected, then here are some possible reactions, especially emotionally. So there may be fear. Many people will say to you, it's not that I'm afraid of dying, but I don't want to deal with the pain or the loss of functioning that comes before death. So the fear may be of suffering, it may be of pain, but there may also be issues, especially for people from a religious background, about what's going to be happening after death in terms of issues of faith and spirituality. So all of those things can end up creating feelings of fear. There are also, for some people, feelings of guilt or regret. The people they weren't nice to, and they can't do anything about it now. The children they didn't stay in touch with, and they're not able to even locate them. I mean, we have a show in Jamaica called the Susan Show, which Jamaicans will be quite familiar with. For those joining from the Bahamas, this is a show where every week the host puts people in touch, family members. So very often you have a parent who was separated from a child at an early age, and 40 years later, they are reuniting for the first time. So if you have somebody who has not had that reunion, there may be feelings of regret and feelings of guilt. There could be grief too, the anticipated loss of connections to loved ones, things undone, anxiety, both about what will the process of death be like, but also for some people, especially the people who've been very pivotal in the family. How are they going to manage? So I was the one who did everything, let's say, for my husband. And I realized I have, let's say, 75, a terminal illness. But I used to cook, wash, do every single thing for this partner. How is the partner going to manage? There can be that sort of anxiety. And of course, the possibilities of depression are also there. So you may not see any of these reactions. There are people who will also welcome the idea of death. For some of them, it's the idea of reunion with loved ones. For others, their spiritual beliefs help them to focus on, I'm going to a better place. So you may get somebody who's very embracing of death as a release and a move to a better place. But for other people, you can get these emotions playing. And you can also get a back and forth between, I'm happy to go, but I'm also anxious for who I'm leaving behind. I'm happy to go, but I don't want to suffer while I'm going. So it's often a mix of emotions that we're seeing at this point in time. All right. When death is near due to illness, then again, I'm going to go through the next couple of slides pretty quickly, especially for folks with a medical background, but not everybody has that. So I'm pointing this out because you'll see certain things. You'll see the profound weakness. Person is much more drowsy and hard to wake. Attention span very short. There can be confusion and little food and fluid intake. So the families, they're trying to urge them to eat, take 2 sips more of the Ensure, but it really is that, you know, they're getting ready to close down, so to speak. Also, you can be having hallucinations where you experience people or things that are not there, and very often it's people from the past. A Jamaican terminology that sometimes occurs is people will say that the person is traveling. Yeah, so they're talking about things from the past, not connected to what's going on now. And they talk about their mother who died 20 years ago. You know, just so there's this focus on the past. But they can actually be hallucinations where they're seeing and talking to the person as if they are present. Changes in secretions, which gives us those rattling sounds in circulation, so the heart rate changes, blood pressure drops, and of course the temperature changes, the person gets cold. Vision may dim, but hearing often persists even when the person cannot speak. For me, I learned this when my aunt was dying, and the nursing staff, I think it was, who said to us, keep talking to her and keep playing music for her, because we think she's still able to hear, even though she's not able to speak. So there was, like, always was somebody with her, we were able to do that. A family member was able to be present with her, and we would, although there was no response, speak, as I said, play the music we knew she enjoyed, this sort of thing. So it's helpful for those who are aware of these issues to be able to share some of this with the family. Because of course, a family member going through a death for the first time hasn't got a clue. So the education becomes really helpful for family members. Of course, once death has occurred, then we know breathing stops. You know, think of you hold the mirror in front of the person from the old days to see if there's any, you know, signs of moisture on the mirror. Blood pressure can't be heard, pulse stops, eyes stop moving, but may stay open. Pupils of the eyes stay large even in bright light, and control of bowels or bladder may be lost as the muscles relax. All right, so that would be physically what's taking place, indicating that death has occurred. Any quick comment? All right, then we'll go on to talk about stages of grief. Now, the stages of grief you're most familiar with would not be the model I have up here. So before I go there, let's just talk a little bit about this idea of stages of grief. Whose model would you probably have heard most about? What name?
Remember the name. I know what you're talking.
You know what I'm talking about?
Yes.
Starts with B.
It doesn't start with B. This one starts with K.
Okay.
It's a double barrel name. It's a lady. I'm sure they still talk about her out there. Kubler-Ross. Ever heard that name?
Yes.
Yes, Elizabeth Kubler-Ross did a lot of the early work on the impact of death and dying, and she put out this stage model, which basically is that when there is loss issues, you have denial, you have anger, bargaining, depression, and then acceptance. And people take that as gospel and expect people to go through, you're going to deny first, then you're going to be angry. And it really doesn't work like that. It really is an issue that what she was describing were some of the emotions that occur for some people, and sometimes the sequence may resemble that, but often it does not. So somebody may not be in denial, but they start off by being immediately angry.
Yeah.
Often there's no bargaining, but there may be depression. Some people take years to come to the point of acceptance or never reach there. So the idea is not that this is a template with any of the stage models. It's not a template that we apply and go, this is it. It is just a way, a framework to help us understand. So if, for example, a death has taken place and the adult child is like, no, I don't believe it. I was just here at the nursing home yesterday. It can't be dead. She spoke to me yesterday. You'd understand that that's a normal reaction in actual fact, because we understand that denial can be part of the process, even though all the mother said to her yesterday was, all right, no real conversation, but this person just was not ready for the mother to go. So you as a clinician, the experienced person, may have seen death coming 3 days before. Try to help them get a little ready. She's not doing so well, wouldn't be surprised if she goes. But they can walk in there and still go like, no, you never prepared me for this. I don't know how this happened. What did you all do wrong? And it's understanding that that is part of the process emotionally that some, not all, people go through. So having paid deference to Kubler-Ross, early pioneer in the 60s, we go on to talk about Bowlby a little later on, 1980. And again, he did a stage model too, where he talked about that numbness and denial. So sometimes it's not denial, but just that the person is not feeling. So people, when they have a death, they expect to react, especially in the Caribbean. We're supposed to cry and bawl and go on a certain way. And somebody comes in, there's no tears, they're very calm. That might just be their personality, but it may also be because it hasn't sunk in yet. All right? So there could be that numbness occurring. Then you get that emotional yearning for the loved one. A sort of way of protesting the permanence of the loss. Boy, I miss them so. Everywhere you turn, you have a reminder, and you're thinking about this person and wanting them back. You don't really want them back necessarily, but what you are registering is your understanding that the loss is permanent. There may also be cognitive disorganization. So people often find concentration difficult. I see that in our students who've lost a parent here at UWI, and inevitably near exam time, if it's early in the semester, they manage. They don't necessarily show up on our doorsteps. But if it's close to exam, they're normally coming in because it is so hard for them to focus, because it is a normal part of that process for us to not be able to concentrate, for us to start a sentence and stop it, and cognitively, we're not flowing. There may be emotional despair, or if not despair, at least strong feelings of sadness. And for some people, there's difficulty functioning. So I've had clients who go back to work and spend a quarter of the day in the bathroom crying. They know they need to resume their regular functioning, but sometimes they're really not ready to be out just yet. But whether the exigencies of the job or they're feeling that, okay, funeral passed, time to go back now, but sometimes there is that difficulty functioning. And then there's eventually a cognitive reorganization, a reintegrating of the self. So now I'm not, you know, the wife of, the daughter of, as my main identification. I'm somebody whose husband has died. I'm somebody, you know, who's lost their parent, whatever it may be. But it is the reintegrating of self. Another model is that of Horowitz, sort of skipping every 20 years. So Horowitz in 2001 talks about the fact that often there's an outward outcry of expressed or suppressed feelings. So there may be the outward, you know, as we said, the bawling, the crying, but other people suppress those feelings. But there's normally some sort of emotional reaction. There can be denial and intrusion. And Horowitz points out, as do some other theorists, that there's often a fluctuation in how people, so today it's not real, and by, you know, tomorrow morning it is more real than I can stand. So you fluctuate between not thinking about it to total immersion in it. And so people often don't understand that when somebody's grieving the loss of elderly parents, for example, that there's going to be this, I cope very well today, right, so they're good now, they can go. And then tomorrow they're bawling the place down. People don't understand that that's normal. So that's part of what's important to get through first, that the movement between expressing really strong, sorrowful feelings and then seeming to cope okay is actually normal. Then Horowitz talks about working through. People begin to find new ways of managing life and the loss. And so that, as we said, the person who couldn't boil water before their wife died learns to either boil water or gets a helper to live with them, you know, but they find a way to cope so they can still eat. Completion, which I found an interesting word myself, might not have been the word I chose, but Horowitz did, where he says, and this is what's important, life feels normal again, but different than before the loss. So I'm functioning, I'm managing, we're back to being able to do things, but I recognize that there is a difference because there was a loss. Another very popular name that you'll hear out there, in actual fact, I use this textbook with the class I referred to, so Warden. He has 4 tasks of mourning. And he talks about accepting the reality of the loss as task 1. Task 2, working through the pain of the grief. Task 3, adjusting to an environment in which the deceased is missing. And task 4, and I like how he puts this one, is to find an enduring connection with the deceased while embarking on a new life. So with my mother having died almost 20 years ago, what's the enduring connection? The fact that we still think about her, talk about her as her children, the fact that we will tell her grandchildren stories about her, so that there is that enduring connection. There are things she loved flowers. And so when I see an orchid, I'll almost always go, especially a certain type that she had, I'll always go, yeah, my mom had one of those. So you have those enduring connections, but you're also very aware of the fact that you are somebody who does not have a mother who's alive. So it's a new life. Where I used to pick up the phone and call her, I now have to think about, okay, who else do I tell this particular story to? So that is his idea of task 4, the enduring connection while embarking on a new life. And the final theorist I'll mention is Therese Rando, and maybe because her name ended in R, why she did this alliteration with everything having R's. But she talked about recognizing, so experience and understand that it is real, reacting, having the emotional response, recollect and re-experience the memories, relinquish, accept that the world has changed, readjust, beginning to return to daily life, and the loss feels less overwhelming, and then reinvest, accept the changes, re-enter the world, form new relationships, and commitments. So that again is just her synopsis of what's happening there.
One question, what she means when she say, which one was it again? Said that the world has changed. Is it meaning that without the person?
Right, so the world has changed because because we're assuming that we're dealing, because especially, well, in her theory, whoever it would be somebody that you would have a connection with, and you no longer have that connection. So that part of your world has changed. As I said, I lost the identity of being my mother's daughter in the real world, okay? So the reality was I could not, as I said, pick up the phone and call her. So my world changed in that way. So you relinquish that part, but then keeping what Warden says in mind, you don't relinquish your identity as her daughter. So there are things I still do, and I say, that's my mother in me, you know? If you've ever read Lorna Goodison's poem, I am becoming my mother. You know, 19 years after my mother died, I can still identify with that poem. Because I see things in myself, which I go, yeah, she put that in me. So, you know, you don't relinquish the relationship, but you relinquish things that would have been part of your daily physical life. Does that help?
Yes.
Okay. You're all right with that, Beth Ann?
I am.
Okay, all right. So talking now not about the tasks as the theorists have it, but looking at the responses, covers some of the same things, but a couple of slides on this. So cognitively, we're questioning and trying to make sense of the loss. And this is why, as for the doctors in the group, you will find that sometimes the family of the deceased are coming to you saying, you need to explain to me what happened. It's not necessarily they're trying to blame you and put a lawsuit on you. It is that it's not making sense to them. Their understanding of the level of illness. So I think, for example, of my uncle-in-law who was hospitalized, somebody who was in his maybe early 60s, hospitalized after an accident, seemed to be doing well. We all spoke with him the night before, went home. They called at 6 a.m. He had died. That was not making sense cognitively to us. Now, from a medical perspective, the doctors will understand what went down between 8 o'clock at night when we left and 6 o'clock in the morning, but it's not making sense to us. And so you'll find that questioning and trying to make sense of the loss, whether it is from a medical perspective or it is from a more philosophical or spiritual perspective. And also, as it says here, they're attempting to keep the lost one present. And a lot of that is talking about them, the stories that people will tell about them. The mementos that we keep are also part of that whole cognitive response to grief. Emotional, the anger, sadness, anxiety, I know we're used to seeing those as part of the response. So somebody loses a parent who's 99, and you're going, okay, they've lived a good life. But the family are telling you how they had all the plans made for next year for the 100th birthday celebration, you know? So there's anger that they didn't make it to this significant, we could say they were a centenarian milestone. And then spiritual, and this is something important to understand, that people may be disillusioned or angry with God, feel abandoned and lose hope and meaning, or they may find meaning through their religious or spiritual beliefs. Now, the latter is not normally a problem because the person is getting help. Because the Caribbean is such a strongly religious place, we find that if people are expressing that God let them down, expressing anger with God, people are quick to go, no, you can't say that. God knows everything. God is wise. God is loving. God knows best. Favorite phrase. I tell people, if you're around people who are grieving, if they say God knows best, agree. If them don't say God knows best, do not offer that as a means of help. Because for many people, they are in a phase where they are questioning how a good God let this happen in this way. Sometimes, especially talking about the elderly, it's not that they've died, but it's the suffering they went through on the way to death. And so people are having this debate with God. And we need to be sensitive to that and not let them feel condemned or judged because they're questioning God. Okay, so I just throw that in because whatever our professional background, there are often the cliches we use, the statements we make, which people find totally unhelpful. So I really just want to stress that point. Meet the person where they are in terms of what's happening, whether it's emotional or it's spiritual. You also get the behavioral response. Of course, many people cry, but do not, how do I put it? People will say, cry, man, it's good for you, to the person who is not crying. Some people don't cry. So again, we've got to understand differences. So half of the families, they're bawling their eyes out, and you have the one standing up over there, not even shedding a tear. It may be their personality that just don't cry easy. It may be that they prepared themselves for this, so they're in a different space than the others who hadn't. It may be that they're the strong member of the family, and they're going, look, if everybody here is bawling, somebody have to drive us home. So I have to keep my head together, and then when I reach home, if any eye water come, you know, that's fine. Any tears come. There may be avoidance of reminders, the keeping or discarding of objects. We can have things like drug abuse, so somebody who never used to drink heavily may, especially you're looking at the widower, but also the widow, could start using alcohol or ganja much more heavily than usual as an attempt to cope with the lonely feelings. And you can again see the opposites. They can withdraw, they don't want to come out of the house and see anybody, or they may not want to be in the house and be out. I think of some of our gentlemen who frequent the bar, and they're at the bar as it open and they close it. And part of that is about seeking company, not just seeking the alcohol. They may not even be drinking more than 1 or 2 beers, but they are around people rather than being in the lonely house. So again, that sort of awareness. Of course, physiological reactions too. You can have insomnia, headaches, appetite changes, weight loss, also possibly even weight gain, because some people do eat more under stress, but we're more likely to see the weight loss and the lack of energy, palpitations. You had somebody who the partner died of heart problems, all of a sudden their chest start paying them too. That's not unusual. Now, it doesn't mean as a medical person that you're dismissive and you go, oh, it's just all in your head. You please do your ECG and your checks. But also one theory to rule out is that it could be a response physiologically to the fact that there has been a loss, which is being stressful. Any comments so far?
It's just...
You want to come a little closer to the mic for me?
It's just a coincidence. I mean, this is now not part of the medical experience at all, but just, you know, sometimes you notice that a couple, especially those who've lived together for several years, when one dies, then the other one dies soon after. It doesn't always happen, obviously, but I mean, I've seen it more than 2 times. So I was wondering if there was anything that, you know, theoretically that has been proposed as a reason for that. It seems more than just a coincidence. Haven't you heard of it before?
Yes, it certainly does happen that one member of the partner who dies and the other one goes shortly after. The one I saw, well, 2 I'm aware of. The job I'm in, when I came, my boss, one parent died. They were both in hospital, elderly, it is. One died, let's say this week. The other one was not told of the death, but died a few days later. So you have those sorts of situations. So that was the first time I went to a funeral with 2 coffins up front one time. The other day I saw something in the paper with something similar, where it was apparently a couple who were going to be buried together. So yes, these things do happen. However, I must confess that I am not aware of any research which will say here are likely possibilities of why. But there are many things, because you're also talking about people who are elderly. Many of them have significant medical conditions, and stress, as we know, will affect your ability to deal, lowers your immune systems, a lot of other things. And the biggest stress on the stress scale, Rahi and Holmes, is death of a partner. So that stress is affecting your body in such a way that you are more likely, if something is not right, to have less of an ability to cope at that point in time, would be one possibility that I offer there. And for some people too, the depression means that they're not taking care of themselves. So not my dramatic story, but somebody who passes on 6 months later. You may find that in the Caribbean, the children are all overseas. So there's nobody at hand to make sure that they're eating, that they're taking their medication. So some of what we're seeing may be just the fact that the person's not really able to give the self-care that's needed, or is depressed and so not putting out the effort in the self-care, and therefore more susceptible again to illness. So that's also a possibility, which is why it becomes so important when somebody has passed on and they have no close family. It's like a couple, one passes and there's no close family, that the community in some way, extended family, somebody really takes on regular visiting and checks with the person who's left behind. And that's not something I think that we're particularly good at. We have good intentions, but we actually may not end up carrying through those intentions. And in a public health, medical way, part of that with our community health aides becomes a roster, possibly, of visitation. So an elderly person, if we have that sort of availability of community health aides, the elderly are checked upon in a regular fashion, for at least 6 months following a bereavement, to make sure that they are going through, a response which involves adequate self-care. Yeah, we have several clinics in Jamaica. Not sure what the Bahamas situation is, but in Jamaica, there are several clinics who have community health aides who will visit and check. They're checking out their health, so they're coming to the depression and whatever. But I'm going, part of what they can also be trained to do is to check. Have you taken your medication? This sort of thing. When they ask you, get out of the house to do something. So things of that nature. A little maybe broadening of their scope, but certainly something that they're quite capable of. I don't know if the Bahamas has a similar system with the community health aides. Do you guys have that?
Not that I'm aware of.
Okay.
I don't know like that.
Okay, so you might just want to check the Jamaican model, because I know, for example, just the clinic next to my ancestral home, can't call it ancestral yet, still have them around, but you know what I mean. The clinic is just over the road, and the community health aide there, as well as working in the clinic, will go around in the community and do things like blood pressure checks. So if you ask her, as part of her job, she has a little area where she will come. It's no cost to the patient. She checks their blood pressure. She checks whatever other vitals she needs to check. And I'm just adding that as part of that, with people who are bereaved, there could also be this additional care factor.
I think that's a very good system. That would be nice. That's certainly appreciated, I think. But here what we do is, if we send a requisition to the nursing staff at the community health, they might go make a home visit only to see that the patient is getting the medications. Maybe there's some dressings to do. They would go home and do the dressings and that sort of thing. But that's I'm aware of that. Yeah.
Right. Yeah. So it's like a visiting nurse system with that one. But the community health aide, I think, carries a slightly wider sense of care. And, you know, and I'm actually extending what they could do in my statement. I'm not saying they do this part that I'm talking about, but I'm saying it'd be so easy to have that done as part of what they do. Okay, moving on then. I want to talk about another model of bereavement by two people called Strobe and Schutt. It's what's called the dual process model of bereavement. And it focuses on the interplay of loss-oriented and restoration-oriented stressors. So the loss-oriented stressors are the loss of the presence of the loved one. So I'm lonely, I don't have the support. Like I said, I can't, you know, I'll burn water if I try. Restoration-oriented stressors are building a new life without the presence of the loved one. So for example, taking on the roles of the spouse and shifting identity from wife to widow. They focused on the females here. I guess because, as we said, there are more of them. But very often we find that one spouse, for example, so in my home, I'm the person who goes online and pays the bills online. So if I were to pass off, I'm not so sure my husband has any idea how to start doing that. So he's either going to have to go chasing down, you know, 5 places to pay bills, or he's going to have to learn to do online payment. So it's things of that nature where you're going, you know, the restoration-oriented stressors. You're talking about how do I learn to do things that were the other person's role, and how do I adjust to that? And what these guys say is the focus oscillates between these two, and is thought to promote healthy adjustment. So today I'm missing you a lot, but tomorrow I'm learning to pay my bills online. So I'm recognizing that I miss you, but I'm learning to cope. And that's what this particular model emphasizes. We also talked too about risk factors for poor adjustment. So male gender is in actual fact a risk factor. So men, you will, if you look, I mean, this is anecdotal, because I'm thinking a lot about men who say in their 60s, 50s, 60s, lose a partner. So not elderly yet, but getting there. And very often you find them with a new relationship. Sometimes within the year, to everybody's amazement and chagrin. Yeah. And they're going like, well, it must have never did love the wife. Why get married so fast? My story is not lack of love. It is that whole thing of adjustment. Sometimes it's because the couplehood was so close that it's been really hard to adjust to the loss. And the way that particular person copes with it is to find another partner. So again, you know, family and friends, we have a very different perspective, but it's about helping them understand that, especially, and I'm being a little stereotypical here, but for men, especially the older men, there's often been the heavy reliance on the partner, the female partner, to make a sense of home. And therefore, that lack is felt very keenly. Whereas for a woman, she loses her male partner, the homemaking function was not such a critical thing. What's often bothering her are the finances. And how am I going to manage financially? But that doesn't create as much of an emotional void. And so she may end up with somebody helping her out financially. So she's in the relationship more for the finances. But basically, if she's able to manage, she would probably take a little bit more time to figure out, you know, do I want another person in this role? Risk factors for poor adjustment too also include violent, stigmatized, or unexpected death. So the person where the partner has a heart attack or the parent has a heart attack, then that, because they were fine. I mean, I remember my grandmother, she'd get up, she's putting on her clothes, she's heading out for breakfast, and she just literally dropped dead, right? So, you know, it takes you a while to adjust to that reality. If a stigmatized death, maybe one, for example, we still have issues around HIV/AIDS. People still tend not to disclose that as a cause of death too freely. So some people will know, but it's not like, oh, what caused a person to die? People nowadays regularly say they had a stroke, they had a heart attack, they had cancer. They don't really say, well, they were HIV positive and they died of AIDS. We still haven't reached there yet. And so that can also sometimes be a risk factor for poor adjustment. Violence, we understand. If the person died as a result of, let's say, a shooting, there was a robbery at the house and an older person was killed, it becomes so much harder for the family to adjust to a loss like that. If there are significant depressive symptoms early in the loss, whether of child or of partner, that's also a risk factor for poor adjustment. If the family members have poor coping skills or low self-esteem, another risk factor. And poor breadth and quality of social support. So the person who was home all the time and, didn't go out much, doesn't go to church, didn't go to, senior citizens club, didn't go to something, often ends up not adjusting that well because of the lack of social support. Any questions or comments? All right, so moving on to talk about normal and complicated grief. Normal, please note the quotation marks. In other words, the grief that you go, intervention probably not needed. This is a process which over time, and I think one of our participants spoke about time being a healer. So over time, you expect the person to be able to make a normal adjustment. So in normal grief, you see the sadness, the loneliness, the longing for the deceased. Please note that experiencing the presence of the deceased is not an unusual symptom. In the Caribbean, we start thinking about duppy. With one day if we have to do something to get the duppy off the person and all these other interesting things that we do. But it is not unusual. And I share my own experience. Again, when my mom died, our house has a corridor. My parents' bedroom at the top, a second bedroom, and then the living room. And my mom, we used to wear slippers. And literally, I would sit in the living room and think I heard her slippers coming down the hall. It was a hallucination in the proper sense. I was hearing something that was not there. But experiences like that are not unusual immediately after a death. So you experience a presence, whether through, like me, hearing the sounds coming down the hall. I mean, thankfully, by then I already knew quite a lot about this, so I was not fazed by that. But you can imagine somebody who's not aware that this is normal as part of the bereavement process, going, what on earth is wrong? As I said, getting somebody to come and cleanse the house of the spirits. But in actual fact, it is a very normal process for many people. They may hear the voice. They may actually walk in and see the person in their favorite seat, just temporarily. The interpretation is going to be they come back and they vanish, but in actual fact, it is not an unusual phenomenon, which we think is coming more from the mind of the person who is bereaved and not necessarily a visitation of the person who has passed on. All right, disturbed sleep and appetite are also quite normal. So some of the hints I would give our students, for example, people often go to medical doctors and say, I need sleeping medication right after a death. And of course, that's a judgment of the practitioner, whether or not it is needed. But I will often say to people who've come to me before they go to the doctor, I'll say, listen, you're not going to sleep good tonight or tomorrow night, but you're probably going to be tired enough by the third night to get some sleep. So I wouldn't necessarily say go to the doctor for sleeping medication right now, unless you're highly anxious, but watch it. And then if by night 3 you're not sleeping, it might well be appropriate to get some medication. But unless the person is very anxious, very hysterical, you might just be able to say, let's see what happens over a night or two. Appetite. I will also advise people, your appetite is not going to come back right away, but you need to hydrate. So you need to make sure that you are sipping. Just sip your way through the day on a little water, a little of the but it things like nutriment or supplement or whatever, something that has some nutrition in it. So it's not the brand name, but just something that's nutritious. You can make up your smoothie, but just sip your way through the day. So you're getting liquid and you're getting some level of nourishment. Nibble on nuts if you're not allergic to nuts. But don't expect to sit down to 2 pieces of chicken from Kentucky and a thing of fries and eat the whole thing, because that may not happen. For other people it may, but some people that's not going to be their experience. Now, what we've referred to as complicated grief, trying to remember, there are 2 terms, only one of which is coming back to me at the moment, but ICD 10, is it 10 or is it latest, or 11, that's the latest one? Getting mixed up with my numbers. So the newest ICD out
10.
is 10. Okay. They actually have a category for what was previously called complicated grief. But for the moment, the name is eluding me. DSM-5, which was the American Psychiatric Bible, did not actually put in a category for complicated grief, but they have it as something for further study. And they have called theirs prolonged, I think it's prolonged bereavement, grief disorder, something like that, PBGD. So it's just an awareness that in the medical fraternity, there is the understanding that grief can become complicated, and you're looking at prolonged duration of intense symptoms. And notice that the duration is culturally determined. ICD actually says you can make that diagnosis that they have after 6 months. DSM-5 was being more conservative and said 6 months in a child, a year in adults. And part of that is just to show right away that the 2 people or 2 bodies doing diagnosis have this big 6-month difference between when do we say grief is complicated and when do we say it's normal. There's that 6-month difference between them. So everybody's agreeing first 6 months, anything can be going on. We're not going to say this is a diagnosis which needs attention. They need support, but it's not something which you need to be seeing a professional for necessarily. Although sometimes a supportive professional helps them in that first 6 months. But then it's like, do we wait a year to make a diagnosis, or do we diagnose in 6 months that this is now a sign of complicated grief? And that's why they said duration is culturally determined. It's also, I think, determined by things like what we talked about before. Violent and disenfranchised grief can take a lot longer, even under the normal grief, to come to a point where it is not so overwhelming of the person concerned. So if you've got a family member whose parent died of an illness where they knew this was likely to come about, you're likely to see somewhere between 6 and 18 months that they've readjusted fairly well. Still missing, still talk about, still wish the trajectory had been different, but they're coping fairly well. Versus the person who may have lost that parent in a violent way, and who 2 years later, the main thing that they're still focused on is why did this have to happen? All right? So at that point, you'll be looking more at complicated grief, but it's coming out of circumstances which we understand why the grief is complicated. So as we said, in complicated grief, there's also marked distress, which continues over months or years, and avoidance of or failure to adapt to new roles. So you could have an older person, for example, again, let's say whose partner dies in an unexpected way, and they just are not able to pick up the pieces, as we'd say. They stop going to things. They used to go to church together. They don't go anymore. You come to the house, and you're visiting them a year later, and the house is in a untidy, unkempt state. And this was actually the person who would keep the house going tidy. So failure to adapt to new roles, marked distress, prolonged duration of intense symptoms. You talk to the person and they're crying still 3-4 times a week, 18 months, 2 years later, that puts us in that arena of complicated grief. Any questions or comments?
Yes, just the part on about the hallucination. How does one deal with that, really? Because if you know someone and they said they're hallucinating, how do you really, could you just let them be? What you did?
Oh, okay, so they're probably not likely to tell you that they're hallucinating. They're likely to tell you that they're seeing or hearing or something, the person who died. Okay, so you just want to hear the story. And if it is a story that is congruent with the death in the early days, I'd be saying if it's not causing them distress, that's marked distress. As a psychologist, as a counselor, I would say to them, this is something that happens to a lot of people in the early stages of grief. They feel the person's presence, they hear the voice, they think that, it feels as if the person's still around. So this is in actual fact something which happens to a lot of people. So let's just see how this goes over the next several weeks or months, because for people who it happens to, it normally starts getting less over time. So if the person isn't ultra distressed about it, I'm going to do some education and I'm going to say, let's monitor. If, however, the person is extremely distressed about it, then I'm going to need to be hearing, more, because this often ties into religious and cultural beliefs. And if it is a case of the person, okay, so in Jamaica, I don't know what this is like, say in the Bahamas, but in Jamaica, for example, when a partner dies, the remaining partner is told to wear red or black underwear. Why? Because the partner who is deceased may come and trouble the genital area, okay? They come and try and clear back them property, okay? So if it is that the person is, for example, feeling the touch of the departed one in the genital area, you are playing right into a cultural belief that is going to create distress. So you find out what they believe about these things. Do they believe the red panty, red underwear? Or did they forget to put it on? And will putting it on help to cure that particular problem? Because at times you may not believe the thing, but because the person is so steeped in the belief, you work with the culture. Again, I reference a lot when I do these talks by my mother's situation. So one of the beliefs in Jamaica too is you need to turn the bed. So the bed head is in a different place, which I guess confuses the poor person when they choose to return. So you turn the bed head, turn the bed in a different position. So when my mom died, one of the family members sat down to inquire, had we turned the bed? Well, my father was not amused. He does not subscribe to those beliefs. And was just like, stop this. I mean, just done with that. Don't bother come through with them stories. So again, not everybody subscribes to the cultural beliefs. So it's about knowing who you're talking to. And so for some people, if they're concerned because they feel the person is not at rest and they're coming back because they're not at rest, it may be a talk with their pastor. It may be about they come and they pray and they bless the house. So it's about understanding that death has many ramifications in terms of how people deal with it. And so it's not just medical or psychological, it is cultural, it is spiritual, and we may have to look around to get the right prescription to help the person cope with what is going on. That was a long answer, Miss Beth Ann. Does that help?
It sure is, and I appreciate it.
Okay. Yeah, but don't get too worried if people are talking about these phenomena. And it's really about helping them to understand that it's not something to worry about too much and it will pass. But because there's a cultural framework they're embedded in, we need to understand that and to work within that. And so in Jamaica, where we are, for example, having a lot more Chinese who are not Jamaican Chinese
Right.
here in Jamaica. If a Chinese person were to come to me, I would need to learn something, what I call the new Chinese, who are not culturally Jamaican. I'd have to learn something about Chinese death rituals and expectations.
Right.
If, as a counselor, I'm going to be helpful to that person, because I have no clue what the death rituals are for somebody who actually is coming from mainland China at this point in time. And what I say could be completely inappropriate as a Jamaican. So again, because our Caribbean islands are very multicultural, we need to bear in mind that we are dealing with different cultures. So Jamaica is pretty solidly Christian with a sprinkling of Rastafarianism, but who all understand the Christian story too. Nowadays, we're throwing a little bit more Muslims. We've got some Muslim temples around the place. So again, if somebody comes to me who's Muslim, they may be Jamaican Muslim, but if I don't know about the Muslim rights, I better learn, whether by asking them or by asking somebody else who is. Trinidad is way ahead of us because they're multicultural a long time. It's Christian, Hindu, and Muslim. There, Guyana, same thing. So some countries have had practice with this long time. Some of us are just beginning to learn that. Okay. Just a comment, remember that normal grief doesn't normally need treatment, although you may need to target some of the symptoms like the insomnia, if they do need medication for that. But you also, and again, I'm not a medical person, but because of what I've seen working in a medical setting, I just remind people, especially with the elderly, be careful not to write too long a prescription for sleeping medication. They're easily confused, especially post-bereavement, and the last thing you want is that they have gone in their confused state and taken, or because they're feeling suicidal, which can also occur, and taken, 3 weeks worth of sleeping medication, and end up in the hospital having to be pumped or elsewise. So I'm just saying the sleeping medication in particular might well be necessary, but where possible with an elderly partner, you're asking somebody else at home to keep the medication to administer, or you are doing it in such a way that they may have to get the repeats rather than giving them a month's supply at one time. So that's just a comment for me in terms of our elderly, especially in the context of bereavement. Complicated grief, definitely you would want to refer for therapy.
Okay.
All right.
After the year, right, when you classify them as complicated grief, that's when you would, I guess, send them to to a psychiatrist.
Okay, so you're asking if after a year, would you, and you're seeing complicated grief, would you send them to a psychiatrist? For not necessarily a psychiatrist, because we're talking more therapy. So some psychiatrists do offer psychotherapy, but not many of them, in my experience, do that, especially around grief. So you're probably looking more at a psychologist or counselor who has training in grief counseling. So UE, in actual fact, now offers a diploma, a one-year online diploma in grief and loss. So we're getting cater to people who do have the training in terms of grief counseling. So because it is somewhat of a specialist area, and therefore you would want to choose carefully who you're sending the person to. My other comment is you don't necessarily wait for the year to go complicated bereavement. If you're seeing that 3 months later this person is not coping, you have to connect them to a counselor, a psychologist.
And then if anything, the counselor would then...
If medication's needed, any good counselor will pass on to the psychiatrist or to a medical doctor who has understand. Because it may only be sleep medication, in which case a GP may well be prescribing appropriately. It may or may not need a psychiatric. Now, if there is depression along with the insomnia, which we're taking as more than, so depression with what I call vegetative symptoms. So the person's unable to get out of bed, they're not eating, etc., then yes, I would say the referral to a psychiatrist would be important. Or the anxiety is so high that again, then, so depression, anxiety would be what would send me more in the direction of the psychiatrist. Whereas if the person is just not being able to adapt to the loss, and maybe the only physical thing is insomnia, then we're saying that very likely your counselor, your psychologist with experience in grief work would be able to help them through, but would also determine after a while, no, not getting where I expect to go, probably need to look at some medication to back this here as well too.
Even for acute grief, wouldn't grief counseling help, or is it that we wait a little to see how people adjust?
Okay, so in acute grief, some people want help. If somebody says, I want to talk to a counselor, I would say, okay, fine, you make the referral. But for many people with acute grief, family support, if it's present, and church support, especially if their pastor, whoever it is, their spiritual leader, is somebody sensitive to these issues, that's often enough to get them through the acute phase. And then we may be looking. Because in the acute phase, and I'm talking acute as in death just happened, funeral coming up, so we're talking probably a 2-3 week right after the death, there is so much going on that the person is probably not taking in a lot at that point in time, and they're busy doing other things. There are points when I have done acute grief work, but I tend to do a 1 or 2 session and then say, okay, come back to me within 2-3 weeks or a month, and let's set up some regular sessions where you're at the point where it's sinking in some more and you're going to need some extra support. Because one of the things that happens with bereavement, everybody's around till the funeral. And 2 weeks after the funeral, who's there? And that's very often when the counseling becomes more useful. But if somebody requests, or if you think that they really are showing signs of, I'd say sort of hysterical type, to use an old word, response, it may be useful for counseling, medical intervention, psychiatric intervention at that point in time. But only if we're talking about the extreme. Most people under the bell-shaped curve are going to calm down with support and be able to manage. But the screaming, throw myself down on the floor when I get the news does not mean I have to be shipped off to the doctor. It means that somebody who's understanding needs to stay with me, let me ball it out, let me carry on, help me to calm down, and then figure out what we really do need thereafter. Were you thinking of something specific though?
Yes, it's one particular case where a gentleman, but this is not for the elderly though, it was a case a lady had HGV1.
Oh, okay.
And she had a small lymphoma, and she had a small child, and I mean she's married. But her husband took it so hard, like I felt like I couldn't, there was nothing I could say or do to help, because he had been going through the process for so long, and in hospital, he doesn't leave her side, and it was difficult to watch. So you almost feel like it's beyond the scope of what you can do, and therefore somebody else needs to help the situation. So the inclination was to try and see if there was some way, somebody he could connect with in that setting. So, but you're right. Maybe just the family support and yeah.
But you're absolutely spot on. I mean, part of what happens, especially for medical doctors, I think, who are dealing with this, is that sense of absolute helplessness. What do you do in the face of a relative who is screaming, bawling, disturbing the other patients on the ward, really carrying on? You really just want to be able to help them to quickly process.
But screaming and the bawling, you kind of
get used to a bit.
Yeah, it's not even that. It was just a very, very, tough. It stands out in my mind because it seemed as if it was particularly, it was extreme. It was marked distress, is what I would consider marked distress in that acute setting for that gentleman.
And so somebody like that, if you're a doctor who is aware that a patient is coming towards the end, and maybe even before that, I don't know how it's actually done, but who's not just their next of kin, but who is the next of kin for the next of kin? Which church do they go to? Are the church people? Who's the pastor? So you have a number or two, if you need to, that you can call and say, you know, so-and-so has passed. It's proving really difficult. Can you come? We tend not to think of that. So we tend to have the number for the next of kin for the patient.
Right.
But what's the embedding, especially for somebody who is end of life, and we see it coming as the clinicians? Do we have a sense of who they're embedded with, who can help them more than we can? Because you're absolutely right. As a doctor, you're more likely to be getting cussed and blamed than you are to be seen as a person to turn to for help, even when you want to help. So who else is there for them? And very often I find clergy can be useful, the ones who are especially understanding, because they come in, it's somebody that they're used to, they give support in the moment, and then we see what happens from there. But it is also appropriate, I think, to say to somebody like that, I mean, I understand how extremely difficult this is for you, and you may not at this point feel the need to see somebody like a counselor, but if you ever do, there's somebody available through the hospital, or there's somebody I know, or you can call me and I can put you in touch with whoever, just to let them know that that sort of help is also available.
I wish there was these services, especially.
I'm sorry, can you speak up a bit for me?
No, I was saying I wish we had these services just at our disposal, especially when breaking bad news in the ICU, in so many places. You have patients in denial, you have patients who in the ICU you would tell them when you have these family meetings that so we lost so and so, and the person would just tell you in the face and say, no, she's there. She's right there. So they're in denial, but it's like in that moment you don't really know. You could just offer some sort of support and so on, but it would be nice to just have that service to actually let them know.
Okay, and it would be helpful. Let me just check with Bahamas. Geriatric hospital, when I hear geriatric, you're dealing with the elderly. Do you have backup services, grief counseling, social worker, anybody who sort of assists when you have to break news that's not good? Or is it just the medical staff who do that?
It's just the medical staff who do that, but the social services are very active. They actually are in the hospital, but during the certain hours, but they usually follow up later on. But in the acute setting, it's only the doctor who's doing it.
Okay, and that's I think how it is in most places. And so part of that is that whole thing of training our doctors so that you can become comfortable enough with something you're going to have to do repeatedly.
And different ways.
In different ways, meeting with different people. So it really is about, I think, as I said, our doctors were, this is not part of early education from my understanding. I think at Mona, they've introduced part of, it's part of one of the courses where they talk about death and dying and breaking bad news. But it is, I think, still such a minuscule.
It is. It's not emphasized to the degree that we have to do it.
To do it, exactly.
Point and just, one exam, counseling, breaking bad news for HIV or a result. Nobody teaches you how to do, bring bad news into that. You do it repeatedly. Sometimes one night and you break 5 days. True.
Yes.
It's draining.
You really do need to have, I think, more training, and it's going to be part of the feedback that you all give. You had mentioned that you didn't have to do this as a medical student. Were you present though when it was done?
Yes, but it's never the same when
you actually are the one. I hear you. So you've seen it done, but to actually be the one to have to do it is a completely different kettle of fish.
It's so sensitive too, because sometimes you're privy and sometimes they ask you to excuse because it's so, so you get a one-on-one sort of situation. You can't witness it.
This is how
this is the right way. And then it's better for us to know exactly what to do for ourselves, because sometimes the people you watch don't do it
too well. That's quite true.
So,
yes.
Sometimes you would have a doctor breaking bad news and he or she is literally telling the family to calm down now.
Yeah, no, calm down, let me finish. It's not going to be well taken by the family. So that's something probably to look at. If not in terms of medical training, sometimes I wonder about stuff like when you're an intern. Are there opportunities in terms of like maybe seminars or something where you're able to get? Is this something that needs to be part of continuing education for young doctors?
Sometimes you call your senior and somebody has died and you're like, you know, I've never broken bad news before. I remember as an intern at QE where I called and I'm like, I've never broken bad news. And they're like, it's okay, then we'll just go ahead, take them into the room and just talk to them. And it's like you don't know which forms and you look even more like what is the just imagine a family member of yours dying and the most junior person of staff having to break bad news, don't know what form to write on, does have to be turned on. I mean, it sends that family into some sort of disarray, like what is going on?
So again, they becomes, as you become the senior doctors, it becomes something where you're looking at what can we do to help our younger ones do this better because it's an important part of their job. Now, they're going to be the family members. You will not be able to calm down. You will not be able to help. They'll be the ones who stick with you. As a psychologist, I have the ones who, whenever I think about them, I go, how could I have done that better? So all of us in the people helping field have those ones who stick out in our mind as I didn't do as much as I wanted to for them. So that's going to happen regardless. But for the majority, are we doing a good enough job? And if not, what could we do so that we improve? What could we do so that we are actually helping our younger ones to do a better job and initiating them in a better way than we ourselves have been initiated?
When my aunt died at the...
Are you guys hearing?
No, not this one, not her.
All right, come a little further for me. All right,
No,
she's coming up.
That my aunt died over by the hospital. I was at school, so when I started this call, something she's died. So when I left and I went over there, I saw my sister,
a little louder.
I saw my sister crying. So I figured, so we are crying. The nurse comes and said I must go up on a chair so she can sit.
The nurses go over on the chairs.
Until today, I hate that lady. If I see her, and no, honestly, and the other people looking at her like, just see that the lady crying. She just died and she's still on the bed. We're crying because we're in Kingston going to school. There is no bigger person here. We're trying to figure out what to do. Crying, crying, crying. And the nurse comes and she said, oh, go over so I can sit.
So she can sit down?
Yes, I got up and I just wanted to say, there was something there to slap her with it. I would have, and it just left a bad taste. And I said, like, seriously, you're a nurse. I'm crying. My aunt died. Why must I shift so you can have a seat? Like, seriously? And it was up to today.
Because, you know, in her head, she sees it's another day. Another death.
Yes.
That's another thing. They don't really understand.
They don't. And a lot of people
one less patient to
will never actually experience death for themselves, meaning within their personal scope.
Yes.
So, you know, they have absolutely no reference.
So I understand that completely because they would actually be on a night when there's 5 deaths, they would be calling you. Then we'll sort them out. We need to take them to the morgue, and they would be happy to see just 5 empty spaces.
Empty beds,
right?
exactly.
No vitals. They don't have to do any vitals.
They want them. So
there's
all right.
people like that in this world.
Okay, so we have a lot of work. Those of you who are in the medical field, a lot of work in terms of sensitizing. The point that was made about not everybody has experienced a death themselves and the difference it makes when you've been on that receiving end as family member to a patient who has passed, that tends to make a difference. But our nursing staff, for example, are very young in Jamaica. So most of them will not have experienced that. Our doctors from my gray hair stage, I look at the white coats walking around Uemona and I go, help. You mean I'm going to be, if I go to the hospital, is you looking someone I'm going to be seeing? You know, so they're really, even our doctors have not had the life experiences, which would make them sensitive. And they're probably not going to have it for the first 10 years of their practice. So, you know, how do we help them to develop that? as part of their professional skills
Sometimes
is something to look at.
Because I can see attempts to, because they put it as part of our examination stations and stuff. But it's a sort of thing, much like a lot of other life experiences, that you cannot teach a person, unfortunately. I mean, we can try, as we have been, but really and truly, it is something that you develop over time, either having to do it over and over, or having a personal experience. That is my personal.
Yeah, and you're right. We can teach certain skills, but we can't teach. Well, we can actually teach empathy, but it's a matter whether people remember it. Because what it is about is empathy. But as you said, if you haven't had the experience, and the empathy isn't as well honed as when you've had it. But the other thing is, even just a debriefing, not after every death, of course, but you have your let's say your interns. Is there a space where there's any debriefing about anything at any point? And if there is, do we include debriefing about how you all coping with the fact that we've lost 20 patients on this ward in the last month? We don't give spaces for that.
I remember there was one situation that was particularly traumatic. I really hope we're not going over time, but that I've experienced a debriefing for, and it was because a patient who was psychiatric patient, schizophrenia, came in and shot himself in front of the whole A&E staff. And so that was big, right? So we got a debriefing and there were counseling offered and so on. But for the
regular everyday
other times, I've never been a part of it.
Yeah, and I'm not, as I said, I'm not suggesting routine debriefings, and debriefing is probably the wrong word at the moment, no. But I am saying that with younger doctors, I really would, as a psychologist, advocate for space for people to process some of what it means to now be a doctor who is dealing with not just death and dying, but dealing with things that really feel outside their scope, I'm sure. And if there's not that space, how do we then help them to develop the attitudes that we want them to develop if we're just leaving them in a vacuum? I mean, it's part of what the clinical years are about. But as I said, it's a big difference between I watch somebody do something and now I am it doing it. However, let me move on, as you said, so that I can indeed cover a couple of other things. But because we have several medical people here, it may have been a good forum for us to bring up some issues for consideration. Go ahead.
Just a quick question. For me personally, I felt personal experience is a greatest teacher to the situation. And then the second thing I wanted to ask, supposing you wanted to brief a family member that something bad may happen in a day or two, or it may happen, what are the words we would like to use when we tell them it may happen?
Okay. I'm not sure I can offer a formula per se, but I think where we start with, for me, it's often helpful to start with what you're observing. So if you're going to have a meeting with the family beforehand, it will be saying, you may have noticed these changes, okay? For us as doctors, that change could be indicating that the person will not be with us for much longer. I can't predict. I mean, I remember standing at my father's bedside in hospital with stridor so strong, he was being heard way down the corridor. And all of us, including his doctor, were sure he was going to die. 3 years later, he's alive. So you can't predict, but you can prepare. So you're saying, I cannot say for sure, but I want you to be aware that we're seeing this so that you can prepare yourself in case this occurs. Does that help?
Yes, and one more quick thing. Suppose in an acute setting when it has already happened, is there any particular way you say that makes it easier from your experience?
Well, I have not normally had to deliver the acute points. I wouldn't say from my experience, really. I usually come in a little later in the process. But having been present when a doctor spoke to my uncle-in-law's family, I really think that, and then when my mom died and the doctor, and so much depends on the setting, because the privacy, can you get into a room rather than you standing up, you know, just on the ward, or in the corridor? Is there a room that we can dedicate for those purposes? And the person, because there was that big difference in between those two settings. So in one, we were put in a room, we were allowed to stay there for a little while, doctor spoke to us. In the other public hospital setting, that was corridor conversation, if you get what I mean. So that sort of thing, designated space where we can hold this conversation, where the family can speak for a little bit, and where you say, you know, and there's really no easy way to break it, except to say, we're really sorry, but we have to let you know. You know, so you're expressing yourself, the fact you're sorry, that at least makes it seem like the doctor is on your side, caring. So we're sorry that we've got to deliver this news, but this happened. This is our understanding of, especially if it's unexpected, because if the person was ill and they knew they were going, that's a little bit different. And then, you know, if you want a few minutes by yourself, and then I can come back and give you some more information about what happens next, or you just want us to talk through what the steps are going to be from here. So it's caring, it's information, and it's respect for what the family need at that point in time. But I definitely am an advocate for if there is a place that we can hold for that sort of bad news conversation.
Right. Away in the Bahamas, we always follow that protocol of having them in a private place before we talk anything at all.
Okay, well, I'm glad to hear that. I'm glad to hear that. Yeah, sometimes there's no space in a crowded hospital in the Jamaican setting, but again, it's working. All that space would have to be occupied by 3 different families same time, but it's something we can still see if we can think about and work on. Yeah. Okay, so moving right along. No, not quite there yet. So just a matter of preparation for death and coping with death and bereavement. One of the things, especially for those who are in the geriatric hospital, or if you're working with the hospice care, there's a whole matter of the US system, for example, has the thing of the living will. So you know what will happen, what the person said they want done with their body. There's a whole matter of the power of attorney for health care as different from the regular power of attorney. Those are things for us to think about, maybe advocate for. And of course, the do not resuscitate orders. Do we discuss those with the family routinely in terms of what happens if? Because again, that's a way for preparing them. If they know that they've signed a DNR, then they pretty much figure, you know, something could be happening here. Although having been asked to sign one, it is such a difficult thing to do as a family member. And it's understanding that while it's routine for the medical person to say, okay, sign here, the person you're asking to sign there is doing their own quiet dying inside. As I say, am I signing away the possibility of continued life for my loved one? So it's not an easy thing to do at all. A comment?
What's a DNR?
Do not resuscitate. So you're basically signing as a family member to say to the physicians, if this person shows signs of death, no extraordinary attempts to keep them alive.
Okay.
Right, if there's a living will, that might be there already. But we're not too hot on the living will thing in the Caribbean, I don't think. Yeah, so again, that's something that... Okay, in a living will. Okay, so it's beginning to take place. Also,
well, just a quick word, how I felt about it. When we ask patients families to, if we offer them the DNS, this thing, and if they want, I know it's very difficult, especially if one that came and if they have other family members, then we would say, have a discussion, and I would tell them, focus on what the person wanted. When he was fine, what would he say? Did he ever say that he wants to go? Did he say, don't, you know, whatever his words were, try to remember them and that respecting what the decision would be, and that you don't have to feel that you have signed what is possible. That
Yeah, very helpful. Thank you. Yes, definitely a useful way to go about it. Okay, so some of the things we can also say to our elderly patients is, have you made a will? It still hurts me. A friend of mine who was diagnosed with cancer, went through rehab, was doing well, but we knew the possibility of the cancer coming back. And somehow we never raised that question of, do you have a will? And he didn't. So it's things like that. There used to be the belief in the old days that if you wrote your will, you did it only on your deathbed. You could die if you write the will. But hopefully people have moved past that, and we need to encourage people, including the younger ones, to write their wills, do the letters of instruction, maybe to talk with their family. My niece in her 30s the other day said she talked to her parents when she's a nurse. She talked to her parents about what she wants at her funeral. According to her, because she said too much foolishness going on at other funerals. So she wanted to make sure hers wasn't a foolish one. But, it's this ability to start talking about death in a setting where we are surrounded by death, but we don't talk about it. Beth Ann, you wanted to say?
No, you touched on a topic because recently my mom and I was talking, and she was saying about at the 9 nights, so when we have the 9 nights, and you find that everybody comes at their house, and therefore she doesn't want that because people don't come, that she doesn't want, and so we had that conversation about that particular thing.
That's really good, and it's helpful for her that she was able to express her wishes to you. As children, adult children, we're often like, oh, don't want to talk about that, you're not when dead, no. But in actual fact, we need to respect the elder's right to say, look, it is on my mind, and I do want to talk about it, and you need to know, and you need to write it down somewhere, because this is what I want. So, even if it may have been a little challenging for you to have that conversation, it's a very helpful conversation. And we need to have more of that occurring in family settings before the person loses the ability, cognitively or however else, physically, to express what it is that they want.
But having the conversation is one thing, but then different story.
Okay.
Everything they said don't do.
Right. So again, that brings us to the whole issue of family after a death. Because what you can find is that one family member says, do it this way, and the other one says, do it that way. And funerals can be the source of the greatest quarrels in family that there have ever been. Yeah, exactly. So he who pays the piper calls the tune, and the tune they're playing is not the tune as they want to hear.
In my community, it happened. My friend's father, one of the bigger brothers, had this thing.
Yeah. No, so we see that. The person who pays, like I said, the big brother paid, and therefore he was the one who said, do it this way.
But he was actually trying to keep on the foolishness, but they wanted to keep the gold bashala. Pretending, because we all know they weren't loving to the man and they got sent in, but they wanted to put on this big old parade and balloon and palm trees and orchestra and everything, and the guy was saying, no way.
Okay.
You weren't in good terms with him, so let us just put him in the hole so I can get back to
and you see, funerals bring out those sorts of things. It's not just about the person who died in our relationship, but it's about our status in the community as well too. So funerals carry all sorts of psychological things with them. And this is why, again, it's helpful to know what the wishes were expressed to all the family, preferably at that point. Deaths in Jamaica, and I think most of the Caribbean, still tend to take place very often in the home setting, but also we're seeing more of the nursing homes. We do not have a geriatric hospital in Jamaica, but we do have several nursing homes. And often this is where a person will be until they die. So there's that level of care at home, care in nursing homes, and hospitals. Because there's more of a tendency when somebody is terminally ill, that if something happens, take them to the hospital. Because we're not sure how to care for them at home. And we're not sure whether or not then maybe they could pull through if they were in the hospital rather than us keeping them at home. So there's that whole discussion too about, you know, people tend not to like the idea of nursing homes, but that may become a necessity because of who's available to care and who's not available to care for. So that discussion is a discussion which, again, it helps if older people have.
Sometimes to hold the family is bonded or something, because I have a centenarian in Maryland and the granddaughter had to stop working to go live with her. And she's so fine with it, she doesn't have a problem.
Okay, and again, it's a family, because no doubt the rest of the family supports the centenarian and his granddaughter, who is happy to look after, you know, grandma or grandpa. Whereas in other families, you would not find that level of support. So different things happen for different people. And one of the things is not to make people feel guilty if they have to put their loved one in a nursing home. And also there's a matter too of respite care. I've seen this with a friend whose husband has Alzheimer's, who's looked after him lovingly for years. But then there was a point where it was putting her own health at risk. And she finally understood that it was okay. They had the means, he can go to a nursing home for a month and she can get some rest. Then he comes back home and, you know, she does this again for 9 months. But if there's something she needs to do, this is where he can go, he'll be cared for competently, and then we move from there. You know, so those sorts of situations. I want to wrap up in our last 5 minutes, though, with a quick couple of slides on palliative care. WHO's definition, it's an approach that improves the quality of life of patients and their families facing the problem associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. So palliative care is paying attention to the whole person. In preparing for this class, I came across this really interesting lecture, probably made more interesting by the fact that I actually knew this doctor, Dr. Rajay, who was at one point Dean of the Faculty of Medicine. And he did this lecture in 2004 because he was one of the early people interested in palliative care in Jamaica. And he points out that it aims to promote both physical and psychological well-being, and it's a vital and integral part of all clinical practice, whatever the illness or its stage. Because palliative care is about making the person comfortable. Key principles: whole person approach, care of both the patient and those who matter to them. Something I think that is often left out in the medical. And those who matter to them may not be blood family, maybe other people, and we need to be aware of that. Open and sensitive communication, including adequate but not excessive information, and that's, I think, often difficult for a doctor to figure out what's adequate but not excessive. But I'm quoting him and he was doctor. Information about diagnosis and treatment options. Respect for patient autonomy and choice, including the choice not to be treated. I think, again, doctors find that very difficult. But you've got an 85-year-old parent and they're diagnosed with cancer, let us say, and they're going to go through massive amounts of radiation, which are going to have side effects. Do you want to put, and as a doctor, the radiation, you know, will extend their life for maybe 6 months, but what's the quality of life? And it's questions like that which I think are important for a doctor to be able to hear from the family and the patient themselves, and to understand if, having shared all you know with them, they may decide no treatment is what we opt for. Because sometimes, I read this really wonderful story, US, read or heard it, but this woman who was diagnosed with cancer in her 90s, and they were going to treat, what did she opt for? She opted for going with her family on a round the US tour. So they had one of these RV vehicles, and they drove through all the different states, stopped wherever she wanted to stop. I mean, it was lovely because of, obviously they could have afforded to do that, but that's what they did. And that, she lived longer, if I remember correctly, than they would have anticipated had she gotten medication. because she had a reason to live. So we've got to remember that when we are dealing, it's that whole person approach that is so very important. So respect for patient autonomy and choice, but it needs to be well-informed choice. And then focus on quality of life and good symptom control. I've actually put that article in the list of articles that you have there. Palliative care provides relief from pain and other distressing symptoms, affirms life, regards dying as a normal process, and intends neither to hasten or postpone death. Integrates psychological and spiritual aspects of patient care, and offers a support system to help the patients live as actively as possible until death. Offers support to the family to cope with the illness and bereavement. Team approach to address the needs of patients and their families, including bereavement counseling, if indicated. Will enhance the quality of life and may also positively influence the course of illness. And then a quick final word on burial rites. And this is taken from work done by Barry Shavans, one of the folks at Mona. And the whole matter of separation and containment, he says grief is expressed through crying or bawling. Transition, dying and burial is a journey, and only on completion does the deceased rest in peace. The public viewing of the body as part of the rites we do, and also traveling past significant places. So I was at a funeral this weekend, and the drive was by the church, young person, the church, and by the home, and then to the graveside. So there's that belief, in terms of the traveling, the transition, which is seen as important. And then veneration and respect. Funerals, as we all know in the Caribbean, have become larger and costlier, and that's another whole session we could do, but we don't have the time. So the fact that people feel that to pay respect, you've got to put out all this money, and people go into debt for a funeral, which is, from my point of view, not necessary, not wise. The whole matter of churching, and we say churching, that's a Christian tradition, but if you're a Hindu, it's cremation, and it's understanding. I was interested to learn that Rastafarians, from my research, didn't seem to have a specific Rasta rite, because they will say they deal with the living, not the dead. Yeah. But in actual fact, many of them will use the Ethiopian Orthodox Church for the ceremony, or they may do something at the graveside itself. All right? But it is important to recognize, as we said, that the rites around death are significant and can bring comfort and help, but can also bring lots of stress to a family. We talked about the fact that funeral can be a source of conflict, and that different people may have to play a mediating role. Again, if the person was in church, because often they're churched, the pastor may be a helpful resource there. And the fact that all emotional wounds may resurface at this time is something to be aware of. So I've sort of run through the last part rather quickly, but I hope that something in this has been useful. You are also given a case. We haven't had time to look at that, but for your own edification, you might want to read that and also read the article it was taken from. Dr. Dingle Spence is one of the oncologists who's done a lot in palliative care in Jamaica, so that article is worth reading in terms of her experience. Any last comments, ladies and gentlemen?
Oh, this was a very good talk.
Thank you. All right, so I hope it really has been helpful, including for those who we didn't see, like Thelma and Kareem. We didn't see them or hear from them, but hopefully it's been, oh, now we're seeing Bethan. Hi, Bethan. Oh, it's not Bethan. Sorry, who's that? Oh, hi, Thelma. Sorry about that. Okay. All right. Bethan was talking to us. Right. Okay. All right. So thank you very much, ladies and gentlemen. I trust something in this has triggered your thinking and may be useful to you in the future.
Thank you very much.
Thank you.
It was a very productive class. Thank you.
You are welcome. This is actually my notes. Check with Miss Falloon because I'd asked her to print the case and the reading list. Just they're either printing or sending it to you, one or the other. Okay. All right, folks, I don't know how this turns out, but Sebastian will come and disconnect us shortly. So all the best as you go through the rest of the course.
Thank you.
Okay.
Thank you.
All right, guys, so I will leave you and go scooting off to the next thing on my list.
Bye. Thank you.
Bye. But you young doctors, if you think about that at all, somebody like you.
Well, I was as well.
Okay.
Yeah, but
Because somebody like Dr. Audrey Pottinger, if you know her over child care, this is one of her specialties.
yeah.
So I mean, there are a few of us who've had training in this area. If you ever get to that point where you say, let's try and do something for the younger ones, then people you can talk to.
Where are you from, though?
Where am I from? As in what Caribbean island? I'm Jamaican, no weird accent. I'm told, but I am Jamaican. Yeah. I grew up with my mother's Bayesian and Vincentian friends.
Oh, the Vincentian is
the Vincentian isn't there? Yeah, when I was a child, we used to have folks hang out from Barbados and St. Vincent with my parents. I think I just like all the sound. So I guess. That's the only explanation I can give.
Yes.
All right, cool.